So thank you. I want to ask everyone to please silence their cell phones if they could, as a reminder, board members and those that are joining us today. And speaking of electronics, you'll see that most of us have computers open. Some of us have computers, iPads, and phones. We're using those as tools to aid us today, and it's strictly for board business work. So officially, this is an official business meeting of the California State Board of Optometry, and disruptions of the board's business will not be allowed. We ask for public comment on each agenda item, and I ask that all of us be respectful of the need to conduct the board's business today. Should anyone disrupt the meeting, I ask the person to conduct himself or herself in a manner that permits the board to transact our business here today. The board welcomes public comments, and I see we have quite a number joining us. This is exciting. And if for some reason, because this is the first meeting I'm presiding over, if I forget to ask for public comment, besides Jessica nudging me and getting looks from some of you to remind me, if the public too could, if you wish to speak on that item, please raise your hand and I'll recognize you and bring you forward. I'd like to remind all speakers that you are requested to speak clearly and loudly so that those who are listening through the webcast can hear you when you come up to the microphones. If one of the microphones is not working, we'll try the other. And then if we still have issues, we'll find a way to have you heard. But we definitely need to hear you carefully, thoughtfully, and loud enough. For the record, we're going to ask that you please identify yourselves and to stay on topic. We're limiting public comment to 3 minutes, and that will not only be 3 minutes during the session for public comments, but throughout the meeting or the meetings of the 2 days to hold to the 3 minutes. And our secretary will be assisting me with that. We plan to end today at 5 o'clock. We may take some agenda items out of order, and there are 2 that I would like to bring to your attention now. The first one will be 9C. I'll be splitting that into a 2-day discussion, giving you information today to think about because it's a process explanation of the committee assignments. And I would like your input after you've had a chance to mull it over for tomorrow's formal session. And also agenda item number 20 will be moved up to 11 a.m. tomorrow. So if you could take note of that. So I officially call the meeting to order, and we'll take roll call to establish a quorum, and Ms. Michelin, secretary.
Ms. Brandvine?
Here.
Dr. Turetsky?
Here.
Ms. Michelin is here. Ms. Burke?
Here.
Dr. Chawla?
Here.
Nope. Let's try that again. Dr. Chawla? Ms. Garcia?
Here.
Dr. Calgucci?
Here.
Dr. McIntyre?
Here.
Mr. Moradami?
I think he's here.
Ms. Salazar Sperber?
Here.
And Dr. Wong?
Here.
Quorum is present.
Thank you. Now that we've established a quorum, we call for public comments for items not on the agenda. The public may provide general comments during this time for items that are not on the agenda. If a comment is related to a specific agenda item, we ask if you could provide those comments during that agenda item. It would be helpful for association purposes. And as a reminder to those of us on the board cannot take any action on items that are not listed on the agenda. So if we start veering a little too far down the path, a few of us will remind us that we need to step back. So are there any individuals who would like to address the board at this time? Please step forward, identify yourself. Don't be shy, okay. It looks like that we have a number who will be participating during specific agenda items. So we'll go ahead and move on to discussion regarding the provision of the optometric services for non-fixed locations, the reason why we're here today hosting this. First of all, I would just like to say that the board recognizes the need to promote access to quality optometric services and patients' desires to receive quality care outside traditional brick and mortar practices. During this agenda item, board members will collaborate with the DCA entities and industry stakeholders to determine potential ways for us to address mobile optometric facilities while maintaining adequate consumer protection. We ask that all presenters remain after the presentations that they give, because we will be having a collective conversation, the board and all speakers, having our questions and public comments during that time. After the presentations too, our board secretary, Ms. Michelin, who's also chair of the Ledge and Reg committee, will facilitate this interactive exchange between all of us. But before we get started, I'd like Ms. Michelin to provide background and context on the current statutes and regulations, history, concerns, and how we got here today in general.
Okay. So board members, how we got to this point, it pretty much started probably about a year and a half ago. There was a work group on mobile clinics. We did have one work group meeting. It was myself and Dr. Calducci. We actually tag teamed it on to one of our Children's Vision work group meetings, and that was really an opportunity for myself and I think also Dr. Calducci to hear some input from some of the stakeholders pertaining to this issue. Following that, the issue came before the Ledge Reg committee last fall. It was myself, Dr. Wong, and Ms. Berber. And we heard testimony and presentations from some of the folks that are here today. We heard public comment. And as we started hearing the different aspects of this issue, we quickly realized that this is a much bigger issue than just coming up with a solution to mobile clinics. So we collectively, and please pipe in the two of you that were there, we really agreed that this is an issue that can be divided up into many different little facets, and that it needs to be looked at from a lot of different perspectives. I think collectively we also agreed that if the board should choose to move forward with any type of legislation or regulation pertaining to mobile clinics, we wanted to make sure we did it correctly, that we put a lot of thought into it, and that it is something that we don't have to come back later and have to clean it up because we didn't think about that aspect when we put forward legislation. So that's really where we got to this point today. I think one of the questions that we asked at the Ledge Reg committee, particularly of legal counsel, is, and we realized quickly, is that it's very much a gray area when it comes to state code pertaining to mobile clinics, that there really isn't any type of overbearing regulations pertaining to whether it's dealing with vets, veterinarians, dealing with getting your nails done, getting a physician. And so looking at what other industries do, I think will give us some input as to what we should do forward. The other big issue, quite frankly, that I'm interested in discussing too is the whole issue of how in California a license for an optometrist is tied to their location, not to the person. And I think going forward, when you look at where services and how services are being provided collectively, whether it's Amazon Prime and a drone is dropping a package at your front door, whether it's calling an Uber to come pick you up, I think that this is something that we really need to look at, because I think from a consumer protection perspective, and that's why we're here, consumers are going to be expecting more services being brought to them as opposed to going to a location. And so I think those are some of the things that I'm interested in, and I think my colleagues on the Ledge Reg committee were interested in discussing, and we had some brief discussion at the meeting, but we realized this is really a broad topic that I think all of us will come with different perspectives and different input, and that's how we kind of got to this. We thought it was important the board collectively have a conversation so then we can move forward with exactly how we would like to divide this up and approach a very big issue that I think is something we will have to deal with sooner or later. I don't know if there's any questions from members of the board or any comments from the two on the committee.
Before I ask Ms. Sieferman to add more color and context to this, I'd like to introduce to the public and our speakers today a couple colleagues who assist us from DCA and serve as legal counsel and overall guider for all the board members. Mr. Kurt Hepler, who has reassumed his role as supervising attorney, and our new legal counsel, Nina Hamilton, and I'll be reintroducing her tomorrow during the agenda item. But I just wanted everyone to know who's up here besides the board members. Now our executive officer, Ms. Sieberman, how about you provide us some additional context to this, and then I'll turn it over to you to start the process of introducing the presentations and our DCA agency colleagues here.
Sure. Well, Rachel did a great job at explaining why we're here and how we got to this point.
No.
Sorry.
There you go.
So Rachel had already explained how we got here, why we wanted to take this a little slower than what was originally projected in the legislation in 2015. And to really start that conversation, we wanted to be able to first see what's already out there in DCA. We understand that there's several entities who are regulating mobile practice and others aren't. So we sent a survey out to the executive officers of all the DCA entities to find out who is regulating mobile practice, who requires locations to be registered. And out of that, the ones who responded that they do have some sort of either statute or regulations related to registering practice locations and monitoring mobile practice, we invited them here to come and give a presentation so the board members have a good understanding of what's currently being done. So hopefully we won't have to start from scratch. We can work from what works from other boards. So with that, if you're from a DCA entity, if you can join us on the panel, and we'll go down the row and introduce yourselves, and then we will pull up your presentations as well. And members, some of the presentations we received ahead of time, some we weren't able to do so, but they brought presentations with them. So we'll make sure to post the presentations on our website as soon as possible so everybody has access to them. All right. So if we want to start here with Tammy, if you want to introduce yourself and where you're from.
Sure. My name is Tammy Gass. I am the Board of Barbering and Cosmetology's project manager.
I'm Jenny Harold. I'm the Executive Officer of the Board of Pharmacy.
I'm Patty Rodriguez. I'm the Inspections Program Manager for Veterinary Medical Board.
Great. Rob, would you mind pulling up the presentation for Barber Cosma?
And you just want to hit slideshow. Yeah, you just hit slideshow. It's all lined out. And there's no, oh, let me give you the microphone.
That's how you sound. Yeah.
Pharmacy.
The California Board of Barbering and Cosmetology is responsible for licensing and regulating barbers, cosmetologists, estheticians, electrologists, manicurists, apprentices, and establishments, which includes mobile units. The board currently has a licensing population of 611,359 licensees. Of this population, 45 are licensed mobile units.
It's all the way up.
The mobile units licensed by the board resemble bus or RV-like vehicles. These units may provide hair, nail, skincare, and electrology services to locations outside the purview of a brick-and-mortar establishment. Owners of the units frequent office buildings, grand opening events, trade shows, and other promotional events. The board has detailed requirements for these units and has set forth the requirements by law and regulations. It has been determined that the unit must Be at least 24 feet in length. Have a self-contained potable water supply of not less than 100 gallons. On-demand hot water, not less than a 6-gallon capacity. Have a self-contained recirculation flush chemical toilet with holding tanks. Have a non-corrosive metal container for trash. Be equipped with a split-lead generator and a remote starter, muffler, and vent to the outside. The storage cabinet doors must have safety catches. All equipment not stored in the cabinets must be anchored to the mobile unit. A ramp needs to be provided for services to disabled individuals. In order to maintain the health and safety of California consumers, the board requires that a person licensed by the board be in charge of the mobile unit at all times, and that no services are performed while the unit is in motion. The unit cannot be used for residential purposes, and the owner must adhere to all local, state, and federal laws, along with the laws and regulations of the Board of Barbering and Cosmetology. The owner may only provide service in the cities and counties within a 50-mile radius from the permanent base address of the unit. Upon request by a board representative, the owner must supply an itinerary showing the dates, locations, and times of service provided by the mobile unit. The licensing application inspection process is the first step in obtaining licensure. The fee for the mobile unit application and unit inspection is $150. The applicant must submit the following items with the application and fee. Affidavits completed by all owners of the business. The affidavits provide identifying information to the board, such as the business status. For instance, it may be a partnership, corporation, or LLC. Any additional board licenses held by the owner, such as a cosmetology or barbering license. If the owner has had any professional licenses denied, suspended, or revoked. If they have ever legally changed their name, or if they have had convictions or pled no contest to a violation of any law in the United States. All owners must complete their own affidavit, and it is signed under the penalty of perjury. The affidavit is a useful tool if the enforcement process should become necessary. Along with the affidavit, the owner must submit the following: a detailed floor plan of the unit, proof that the owner either owns or leases the mobile unit and equipment, a copy of applicable city and county licenses or permits to allow operation of the unit in the territory where the services will be performed, a copy of the California driver's license of the person who is responsible for driving the unit, proof of vehicle liability insurance as required by Section 34630 of the California Vehicle Code, proof of compliance with applicable city, county, and state plumbing, electrical, and fire laws, the permanent base address from which the mobile unit operates. The final section of the application includes a signed certification that the owner of the unit has read and understands the information provided by the board in the Know Your Workers' Rights publication. This information provides the owner with a brief summary of basic labor laws. Once board staff receives all the requested items, staff then completes the top section of the mobile unit required equipment list and mails the applicant an initial application approval letter. In the letter, the applicant is instructed to email the board's establishment desk when they're ready to schedule a compliance inspection. Upon receiving this notification, the board's establishment desk notifies the applicable inspector to set up an appointment for the verification of the compliance inspection. After the unit inspection is made, the inspector forwards the inspection report and the completed mobile unit required equipment list to the board, and the license can then be issued for the unit. If upon inspection there are items noted that are not in compliance, the board's establishment desk will issue a deficiency letter and hold the application and fee for a period of 1 year. During this 1-year period, the mobile license unit's owner may request an additional inspection for compliance. In the last 5 years of the units inspected, half received no violations. When cited, the most commonly cited violation is the California Code of Regulations Section 979, which includes proper disinfection of non-electrical tools. Violations cited under this section usually are in regards to the proper labeling of clean or soiled tools. The board has only received 4 consumer complaints regarding mobile units in the last 5 years. If the board were to receive a viable complaint and a directed inspection revealed egregious health and safety concerns, an enforcement case would be opened and assigned to an enforcement analyst for follow-up. The analyst would reach out to the owner, offer education on how to get into compliance, request completion of an enforcement declaration form, and at that point either close the case if the analyst is confident that the violations have been corrected, or issue another directed inspection. If the owner does not fall into compliance after a period of time and continuous efforts on behalf of the enforcement analyst have not yielded the desired results, the board may choose to pursue formal disciplinary action, such as probation or license revocation. Within the last 10 years, the board has not had to pursue formal disciplinary action against any mobile unit. Thank you for the opportunity to briefly summarize the board's mobile unit program. Are there any questions?
Sure thing.
Good morning. Again, I'm Jenny Harold. I'm with the Board of Pharmacy. I'm the board's executive officer. In the area of pharmacy, we generally do not have mobile pharmacies. It's kind of a risk to us to have drugs on board and being moved here, there, and everywhere. But we do have 2 circumstances where we have the authority to issue temporary licenses or mobile licenses. The first is a pharmacy that may have a flood, a fire, or something that's destroyed the pharmacy. There they can bring in a mobile unit, operate from a mobile unit that is contiguous to the pharmacy for a period of time. We allow them to occupy the premises. They have to provide for security, and they have to operate the mobile unit exactly like they would a pharmacy, where the pharmacist has to be present, things along that line. And then within 48 hours, I believe, yes, within 48 hours of the return to the permanent location, the temporary location can no longer serve as a viable pharmacy. So this is done so that the pharmacy can continue to take care of its patients. It's generally pretty short-term in nature, and it is not mobile. The only mobile part is they bring in something that is mobile, but then, as we used to say, take the wheels off of it so it's not mobile. So it kind of locks there. We treat them otherwise just like pharmacies. And we inspect accordingly. But generally, we don't use that option very often. It's available. The second form that we use is one where there has been a disaster declared in a county, locally, federally, or by the state. And in those cases, you can actually have a mobile unit that will move to the location where the disaster has been declared and provide services to people there. During times of emergencies, it's not at all unusual for people to suddenly leave their homes when they've been basically told to evacuate their homes, leave their medicines in the home, not bring the things they need, and then present at a pharmacy trying to get their medications. What we try to do in those cases, and we've got very broad authority, we've been pretty active in the area to provide emergency provisions that should the governor not declare the waiver of certain things, we have the ability to declare waiver of certain pharmacy law in the event a state, federal, or national or local disaster has been declared. So in this particular case, we have mobile units, and where I don't believe we've ever used these, and they truly are mobile. They have to be in the location of the county or the area that has been declared a disaster area. And where they used these was during Katrina. They had such a wide area that had been devastated, literally, and the disruption to public life and medical services and everything, people were scrambling about what to do. In this particular case, they had some mobile units that they would bring in, and they were usually operated by the big chain store pharmacies, and there weren't a lot of them, but they could go to particular locations and provide services that way. And so those truly are mobile, but again, we haven't really used them in California. They have to be linked to a pharmacy that is in fact licensed in California. So if I was in Nevada and owned a pharmacy and I had a mobile unit that I wanted to bring into California, there would be a bit of a problem there, although again, we can waive statutory law in order to provide for public health and safety, which we probably would do in that case. The goal is to just get patients their medications. So, Fortunately, we haven't had to use it.
Hi, I'm Patty Rodriguez with the Veterinary Medical Board. The board does license all premises where veterinary medicine is being practiced, whether that's a fixed location, a mobile unit, or an ambulatory or house call practice, as well as vaccine clinics. For purposes of this chapter, if the premises, the mobile premise is tied to a fixed premise, then they don't need to acquire a separate registration. However, if it's a hospital on wheels, a veterinary hospital on wheels, then they do, if they're not tied to a brick and mortar building. We randomly inspect these vehicles, these mobile clinics, on an annual basis, and the MGL has to be a licensed veterinarian, has to provide a reasonable presence at the location, and typically anything they are to oversee and make sure all the minimum standards are being met. If there are any issues, and we haven't had, that I can remember, any disciplinary or complaints specifically regarding a mobile clinic. But however, it all comes down to the managing licensee, and they are responsible for anything that occurs. If they can have a relief veterinarian if they're not present. A veterinarian has to be present and may not necessarily be the managing licensee. But whatever happens in that mobile clinic, it is the managing licensee's responsibility. And as far as their registration, they do have to provide a physical address, and that is where the medical records and the drugs, controlled substances, are being stored. So if there were to be a complaint or any kind of disciplinary action, then it would all go down, it would all be tied into that managing licensee. So if we do have to conduct an inspection, we may inspect the mobile clinic as well as their, and many times their physical address is their residence, because that's where they maintain drugs and records. So we will show up at their residence if that's the physical address and conduct the inspection there as needed. That's kind of in a nutshell what our program for mobile clinics. Mobile clinics are a small population for the hospital premises, but we do inspect them every year. So that's kind of about it for the veterinary program. If you have any questions.
Thank you. I'd like to turn it back to Ms. Michelin if you'd like to facilitate questions from the board as well as questions from the public.
Okay, so I'll start with my colleagues on the board. Are there any questions? I'll start over with Donna. No? Mark? Do you have any questions?
Yes. So this is a theme that you might hear from me all day, but I'm going to pitch a hypothetical for the three of you, and it'll help me understand the regulatory nature of it. So as I understand the board and statutory rules, the mobile clinic, a portion of this mobile clinic discussion affects the ability of optometrists to make house calls, from what I understand. If I'm wrong, correct me in the course of our conversation. So I'm going to separate, for the purpose of my questions, the mobile clinic portion and the house call portion. I think they're interrelated. But for the purposes of my question, I'm going to focus on the house calls. So this is a situation. Let's say my mother is in a nursing home or is homebound, and I'm having care provided to her at home. And so if I want to have her get a haircut, do the laws permit or prohibit a barber or cosmetologist to go into the home and provide her with a haircut? If she's homebound and I need to get her some drugs, prescription, do the laws prohibit a pharmacist from delivering that prescription to her in her home or nursing home? And if she has a pet and the pet is ill, do your laws and regulations permit the veterinarian to go to her home and look at the dog and say, oh, your dog has whatever ailment. So if you can answer that question for me.
Sure. Regarding barbering and beauty services, we have an exemption for incapacitation. So how that would work is the person wanting to receive the services for their mother would call into the salon. The appointment would be booked through a brick and mortar salon and would be listed on their appointment book. And then the licensee would be able to go to their home and provide the services.
And that's separate from the mobile clinic?
That's separate, yeah.
Thank you.
In the case of a pharmacist, the pharmacist can provide professional services, cognitive services that a pharmacist would perform anywhere the pharmacist is. In the case of drugs, a pharmacist could deliver patient-specific drugs to someone in a home and could provide pharmaceutical care to that patient in the home. Pharmacists cannot carry a drugstore with them. There is no black bag requirement or allowance for them to really carry unlabeled drugs into a situation. The medical supplies they might be able to bring, but things that are prescription only, there's really no authority in the law to do that.
In terms of veterinary care, there are ambulatory practices, and so they would be allowed to provide veterinary medical services in a home, and they would be required to they are allowed to carry controlled substances as long as they are properly stored in their vehicle, and then they're not allowed to store them in the vehicle. They would have to, at the end of the day, remove them and take them and store them properly, usually in their home.
And those rules are separate from your mobile clinic rules, is that right?
That is, no, that's part of the mobile.
Okay, thank you.
If I may, I have one thing I need to add. The other thing is, of course, in the case of patients receiving drugs in their home, you can have other people deliver, or you can have mail order delivery. And a lot of specialty services now are delivered directly to the patient in home.
Thank you.
Ruby?
Okay, in relation to trying to tie the optometry part of it to it, we're always looking for securing privacy information. How do you handle privacy information for your patients in these clinics? Do you have them in the mobile clinic and do you have them stored somewhere else?
Ours are computerized. There may be some, we don't use these kinds of services very often, fortunately, but pharmacy, in order to get reimbursed, probably very much like your profession, everything's online. There's no requirement that it go electronic, but pretty much everybody is electronic. And if we go up north to Northern California, there's probably some areas where during the wildfires, for example, if they were trying to network, there would have been problems trying to do that because they just have limited reception. In that case, we'd expect them to keep paper records and then transmit when they get to an area where they could. But again, the goal for us is to take care of the patient. The record keeping follows that, but it's not the predominant concern. We really want those patients taken care of. And sometimes they cannot sometimes even validate that there's a prescription there. And again, that becomes the pharmacist's professional judgment about how they care for those patients.
And regarding the Board of Barbering and Cosmetology, we don't keep medical records. They're outside of our scope of practice. But an issue could arise with a client skincare profile, and generally the stylist or the esthetician would keep those records with them, and they would be stored at the establishment, the brick and mortar establishment.
In the case of veterinary medicine, we do maintain medical records. Of course, HIPAA doesn't apply to us, but those are stored with the veterinarian. If they have a mobile practice, then it will be stored typically at their residence. In a fixed premises, it would be stored on the property.
Any question? Okay, Deborah.
Question for barbering and cosmetology. What was the purpose of imposing a 50-mile radius limitation?
All the regulations went into effect in 1994, so I'm unclear why they defined 50 miles as opposed to 100 miles, other than just to make sure that the inspectors would be able to complete their inspection if they were assigned to that area within a normal drive time day. So our inspectors are assigned different territories, and when an inspection comes forth, it would probably, I'm thinking that that's probably the reason, just to make sure those inspections could be done timely.
Okay, thank you.
Barbering and cosmetology. There, in the presentation, it noted that date, time, and locations required when somebody's operating a mobile unit. Where's that posted and how is it obtained by the public and by the board?
When an inspector, that portion of law was written for when an inspector comes into an establishment that they know has a mobile unit. They can record those, take those records and see where they're at any given day, where services have been performed. Most of the mobile units that are utilized by our licensees are for like trade shows or grand openings. They're not generally used for home-based services. We have another license type that we're in the process of developing for personal service permit. So those records would be kept at the owner's and the base address that's on the application for licensure of the mobile unit.
Okay. So, but the records then are all looking back, it's not where you're going to be going next
Exactly.
week or something.
Our
Okay.
mobile unit program is completely complaint-driven. Yeah.
And a question for the Veterinary Medicine Board. Looking at what was presented in the PowerPoint, it looks like you're talking about like a mobile type unit like barbering and cosmetology has, but I've seen lots of vets that drive around with like a pickup truck that has a special thing on the back to hold it. Are there any specific requirements in that case, like if somebody's dealing with large animals where they're not going to need to have, you know, floor and a table and things on that order? Does that eliminate those requirements?
That's more ambulatory, and they'll do barn calls. So they won't have, some of these requirements won't apply to them because they'll be actually practicing veterinary medicine in a barn. The drug security controls are still in place. They still have to maintain records. They won't have floors, tables, countertops that are can be sanitized because they're not performing aseptic surgery procedures. So there is a little leeway there.
Okay, and there is, just so I'm sure I have this right, there is no requirement that there's a brick and mortar location. You can be a completely mobile veterinary service and you don't have to have a brick and mortar location.
Correct.
Okay, thank you.
Mm-hmm.
I'll come back to Sid. Maria? One.
For Cosmo and Vet, can you quantify the number of mobile units versus brick and mortar? Just trying to gain perspective.
Yeah, BBC has about 46,000 brick and mortar establishments, and we have 42 mobile units. So,
We have 3,500 veterinary premises, and I would venture to guess that maybe 10% are mobile units, mobile clinics.
So for the vet board, what is the cost? Is there a separate cost, like with Barbary, in terms of getting a separate license for a mobile clinic?
The premises permit, and the premises permit will cover a fixed premise, mobile unit,
Okay.
ambulatory, barn calls. It's the same one, I believe it's $200 fee.
Annually?
Kelly could probably tell us how much it is. She used to process them. Was it 200? It's
And that's
200.
an annual?
I'm sorry?
That's annually, 200 annually? The
Yes.
license is annual? And have either one of you that have the mobile clinics, are you seeing more of an uptick in terms of licensees wanting to have that ability to have a mobile clinic? Are you hearing anything from consumers in terms of, have they been asking about the ability to have mobile clinics or to have folks, and maybe not so much on the vet side, because I think it's kind of embedded, but are you seeing more folks asking about it, considering it seems like more and more services are coming to people as opposed to people going to the service?
not on BBC's side. I think 10 years ago when I started working for the board, we had about 12, and now I think I mentioned there's 45. So it hasn't been a steady stream. What we have seen being asked for is the ability to perform services in a household setting or a bridal suite, and we are working on regulations for that. So.
For veterinary medicine, I think we're seeing an upward trend of house call practices, and in particular, at-home euthanasia services. At-home euthanasia services, we're seeing an increase there.
Wasn't there an LA Times article or something about, I read something about that, folks wanting the euthanasia in their homes. Okay. Lillian, any questions? Sid?
I have a question for the three of you. It would help if I turn my microphone on. For nursing or other healthcare facilities, the services you provide, do you consider them to be house calls or a mobile clinic?
For us, a mobile clinic is a hospital on wheels. So if they're setting up at a park, but it's, then that would be a mobile clinic. If it's a vaccination clinic that's being set up in a parking lot, that's also under, like a mobile clinic. But if they're doing the services in the home, then that is ambulatory.
And for BBC, the mobile unit on the presentation is more for like grand openings or where you have a platform artist performing different techniques, teaching licensees. That's where we see our mobile units being used. We do have the exemption for incapacitation for house calls by stylists who their clients cannot physically get into the shop or salon. And then now we have a third avenue that we are looking into providing the personal service permit, which would allow someone to obtain a license to be able to go into a home, bridal suite, anywhere.
And for pharmacy, it's a little different because the drugs generally are delivered to the patient wherever the patient is. So in a skilled nursing facility, you've already got that licensed and it's very structured and you've got licensed staff in it with very detailed scopes of practice what they can do. In residential care homes where the patients are a little more autonomous, there the drugs are usually somehow given to the patient, whether or not they're delivered in. Family member picks them up and brings them in. The patient arrives at the residential care with them, or they get them from mail order. There's probably less in-person service in a residential care because the patients are a little more able to take care of themselves.
So I have one question. This is for veterinary. Are there any guidelines or regulations in place in regards to follow-up care? So for your mobile hospitals, if a pet needs surgery, is there any requirement that the clinic has to come back, or is it sort of up to the individual unit?
If it's a hospital on wheels, they may be able to perform the surgery right then and there. If it's something that maybe they don't have a surgical equipment there, especially in a vaccine clinic in that type of setting, they may recommend to the owner, you really need to go see a veterinarian, and this animal may need surgery or more care. So if they can do it there, they in a mobile unit they can. But if it's more of a vaccine clinic type of thing and they don't have the equipment, they will strongly recommend the owner to visit a veterinarian in a fixed premise.
So if they're able to perform the surgery, and let's say the pet needs to be seen for follow-up 2 days later, is there any kind of regulation where you say if you were able to perform those surgeries, you need to come back in a timely manner, or it's sort of
There isn't.
And more for the vet board, you may not know this off the top of your head. Do you know how many mobile services in terms of veterinary care are being done in areas of the state that have less accessibility to a brick and mortar hospital or vet? Are you seeing folks that want to go into communities that are underserved? Or are you seeing more of these coming up in, like a San Francisco, San Jose, where there's just more people there?
I don't have that data. I can certainly get that and get back to you. I couldn't tell you where most of our licensees are in Southern California, but we could go back and do some research and kind of see where those mobile practices are.
Okay, thanks. And Mark had a question.
So for the barbering board and the veterinary board, the the rules allowing for incapacitation and for ambulatory care, are those a function of regulation, or are they expressly provided for in your statutes?
It's statutory for us.
Same here.
Any other board members have questions, comments? Are there any members of the public that have any questions of our presenters? Okay.
I'd like to thank the three of you for coming today and sharing on behalf of our DCA fellow colleagues in our brethren agencies, so thank you.
You're welcome.
So now, Ms. Sieferman, if we could move towards the industry stakeholders and corporate side.
Yep, so we also invited a number of entities who are providing mobile services. The goal was to give the board a better understanding of what's currently in practice and ask any kind of questions to give us a better understanding of what we're regulating. So if you're from an entity that's operating a mobile unit, if you can come to the panel. Rob, would you mind bringing some more chairs?
And if we could share the microphone. There was a third I thought I saw earlier. No, okay. All right. Ms. Sieferman.
All right, so if we want to just go from our left to right and introduce yourself.
Do I need the mic? Can you guys hear me okay? Got you, okay. Better? Okay. Thank you for having me. My name is Dr. Arina Patel. I'm an assistant professor at the Southern California College of Optometry at Marshall B. Ketchum University.
Good morning. I am Seth Shallett, Chief Executive Officer for Prevent Blindness Northern California, and our mobile optometric program is called See Well to Learn. Thank you for the opportunity to address the body.
Hi, good morning. I'm Jeremy Bornstein, Inside Counsel and Vice President of Growth for 2020 Onsite, mobile optometric practice organizer in Massachusetts.
Good morning, I'm Damian Carroll. I'm the National Director of External Relations for Vision to Learn, a nonprofit serving school kids in low-income communities.
Good morning. Thank you for having me. I'm Gil Melgoza. I manage the Mobile Clinics program for VSP Vision Care.
Good morning. My name is Meredith Whiteside. I'm an associate clinical professor at UC Berkeley Optometry. And I just want to be on the record that we don't currently have a mobile program, but we've had one in the past.
Dr. Patel, if you mind starting us off with your presentation.
So again, thank you for having me here and allowing me to be a part of the discussion and to share what we do at our university. Before I get into my presentation, I think it's worth thinking about what are some of the barriers out there that are preventing the community members from receiving the health care that they need. And there's a few important ones to think about. One is education. So are patients and individuals not going in for their eye exams because they don't know the importance of it? Maybe they can see well, and so they think there's no need to go in for an evaluation. But we know that there's a lot of eye conditions that can be manifesting and that won't affect vision until later on. And unfortunately, we can't often reverse that process. So is it a lack of education that's preventing them from going in for the examinations? Is it due to financial concerns? Perhaps they can't afford to take a day off from work, and that's why they're not able to go in to receive their health care. Or perhaps they can't afford it. They're not able to pay for the examination or for a pair of glasses. Now, maybe they have insurance that covers these evaluations as well as glasses, but that goes back to education. Maybe they don't know that their insurance covers these services. So those are some things to keep in mind. And then, of course, access to care. I think that's a really big one, and that's where the mobile clinic discussion ties in very well. But it is important to remember all of those points, and I'll highlight them again in our presentation. So I was asked by the board to share what we do at our university, at Marshall B. Ketchum University, and we actually do not operate a mobile clinic in the traditional sense, but what we do to serve our patients in the community is we participate in various clinics. One of the big ones is Care Harbor, and this takes place in Los Angeles once a year, where individuals from the local community will come in to receive not just vision care, but overall health care as well. And oftentimes, they're going to be coming in because they know of this clinic, they know that it's going to be on the schedule, and so they'll line up out the door to come in and receive these services. At our event last year, we saw over 1,000 individuals, so we really do have a big turnout. And then we also participate in the Special Olympics program. Many of you might be familiar with it. For those of you that aren't, what Special Olympics is, it's a great platform that allows individuals with intellectual disabilities to participate in different sporting events. And it promotes, sports, it promotes healthy competition, teamwork, leadership. It's an overall fantastic program. And they're very great at promoting the importance of health. To be a good athlete, you need to be healthy. So at these events, our vision services are provided, but in addition to that, there's hearing, podiatry, general health care, nutrition, dentistry. So all of those components take place at the Special Olympics. And then the third point here, and I'll talk about this in a few slides, is Children's Vision Days. So this is a program that's unique to our university. So going further into the community outreach, here's a list of the different tests that are done in our evaluations. And the individuals that participate, we primarily have our optometric interns, and we can see in our picture we have quite a number of students that come out to help out at these events, and they really enjoy it. It's a great experience. They're able to serve their community, and it's a fantastic educational experience for them as well, too. And then, of course, we have doctors from our university and affiliates of the university as well. All of the services and glasses are provided at no cost to the participants. And for those that need further follow-up care, perhaps we need to evaluate their glasses in a couple of months, or maybe we found something that warrants further testing, they're going to be referred to local doctors in the community. And the way that we have it set up, especially for Care Harbor, is we have a lot of clinics that are very close to that facility that have agreed to provide a lot of these services at a very discounted rate, or often pro bono. So at no cost for the participants, so they are able to get the follow-up care that they need. And then the last point here, this is a very important one, is this is a fantastic platform for education. And this is twofold. We're able to educate the participants on the importance of good vision and eye care. We're able to inform them on what we found, what follow-up treatments are recommended, so to give them that information. We share with them that the testing we've done, it does not take place of a comprehensive eye examination, so we do reiterate the importance of getting that full examination done. And then at Care Harbor, one component there, which is very neat, is there's a station set up at that health clinic where after the participants have gone through all the different specialties, there's a doctor or a nurse that will look through all of the data, and they'll speak to the participants about insurance coverage. So they're going to look up to see what insurance plan do they have, what services are covered, and oftentimes these participants have vision coverage. It will cover an eye exam, it will cover glasses, they just don't know that. So that's a really good thing to be able to share through these programs. And the Children's Vision Day, so I'd mentioned this earlier. This is something that we provide at our clinic. We have about 45 days of this over the course of a year. And what we do in our Children's Vision Days is we bus in children from local elementary schools. Currently, we're working with Anaheim and Santa Ana, the Title I schools there, and the children are bused in. So they're going to come to our clinic, and we'll be providing comprehensive eye exams for them, including dilations. And for the children, we often need to do a cycloplegic evaluation, so using a different type of an eye drop to be able to verify their prescription, and we're able to do that in these comprehensive eye examinations. And these services, as well as the glasses, are provided to the children at no cost. So I mentioned earlier we don't operate a mobile clinic, but I was asked to come and present what it is that we do participate in at our university. But being involved in this discussion, I started investigating and researching more about mobile clinics because it wasn't something I was very familiar with, and I certainly wanted to learn more. And so I spoke to colleagues. I looked up different companies online to see what's currently being done. How can this be helpful? Are there any red flags that we should watch out for? And so comprehensive eye exams, we all know that's a very important thing. That's how the best way to be able to assess an individual's vision and eye health. And as I was learning and researching more about the mobile clinics, what I saw on a lot of the different websites was that individuals can come and get an eye exam on a mobile clinic, and it would be 15 minutes. It's in and out. You can get it done during your lunch break. In the order of dilations, that was presented as something that can be skipped, and in lieu of a dilation, a picture can be taken of the back of the eyes instead. And unfortunately, that's not the gold standard, and that's starting to affect the quality of care that we're providing for our patients if that is, in fact, the way some of these services are being promoted. When we do a dilation, we're able to get a very thorough look and evaluation at the back portion of the eye. But by taking an image with a camera, our view is limited, often limited, and therefore we might be missing certain conditions that might not affect vision early on, but they can be vision threatening later on. And so that was something that was concerning to me. The other thing I was thinking about was going back to the cycloplegic evaluations. So that's when the eye drops are placed in the eyes of children, especially ones that are getting glasses for the first time or if they're found to have a high prescription. And so I'm thinking about the format of the mobile clinic. And again, I'm not very familiar, and I look forward to hearing more about it as we move across the panel. But do these clinics show up to the schools, and are the children being evaluated? Are they pulled out of class and getting this evaluation? Are these cycloplegic evaluations done? If so, the drops should be placed in the child's eyes, and it takes about 30 to 45 minutes for the drop to take effect. So logistically, how is that going to work if this is being done in a school setting, and is it something that is being done? So those were some questions that I came across. I also thought about contact lens evaluations. So the way that contact lens evaluations work is if you want to wear contact lenses for the first time, or perhaps you wear contact lenses and you want to change into a different lens, then you're going to be fit in that particular lens, and you'll be asked to wear that lens and come back for a follow-up about a week or so later. So I wasn't sure how that would necessarily work with a mobile clinic, is if they're coming in, perhaps they'll see them for that first visit. Do they contract out to an outside location or another doctor for that fit and follow-up 1 week later? If so, there may be a little bit of a disconnect at different doctors managing this patient. Maybe one doctor has their own preferences, but the second doctor is seeing the evaluation in another manner. So that was something else that I thought about. And that ties into the next point, which is that continuity of care. So in an ideal world, patients are going to be seeing the same doctors, both short-term and long-term as well. And that's important for a number of reasons. One, it's best to manage that patient when we know their history and we're able to see them on an annual basis. But in addition to that, the patients will build a relationship with their doctor. And if a patient trusts their doctor, they're going to be a more compliant individual. They're going to follow the recommendations. They're going to take the medications as recommended, and they'll be more likely to return for care. So for these mobile clinics, what happens in the long run? If a patient's asked to go in for a 3-month follow-up and they forget, they don't go in, they're not sure about it, is there anybody taking ownership? Is there somebody saying, hey, it's been 3 months, you haven't gone in, go ahead and come in and get an evaluation? Those are some things that I'd be curious to learn more about. And then the last point, and this one is a really big one, is related to access to care. And, we tie this into the mobile clinics. Are there areas, rural areas, where we don't have eye care practitioners, or maybe they're limited and we don't have enough to be able to serve the population? A mobile clinic can come in and provide these services. That's a fantastic situation. I think that's ideal. The need is there. The individuals will receive the care that they need. But I also think about it from a global standpoint. If these mobile clinics are going to a business or that type of an entity where those individuals, they have the vision insurance, they're able to go in and get a full comprehensive exam, but now there's the appeal of a shorter exam, skipping a dilation. If I was given the option to not have my eyes dilated and have blurry vision, but take a photo instead, I would certainly prefer the latter. So now is it going to start affecting our quality of care? And are we taking it away from some of these individuals that are doing the ideal? They're going in, they're getting that full comprehensive eye exam, and are we going to break something that's already fixed? Again, some questions that I came up with, and I'd love to hear more about it from the panel. So thank you again for the opportunity, and I appreciate it.
Thank you very much. If we could have the balance of the presentations present relative to the services you provide, et cetera, and thank you for teeing up the facilitated discussion of comments because you bring up some very valid points, but we'll not use this initial presentation time to address those points if you don't mind. If we can save that for the board questioning and additional public comments, that would be helpful. So we'll move to the next presentation, and thank you.
Thank you. See well to learn from my opponents. Thank you for the opportunity today. I also would like to say at the onset, we appreciate the opportunity to be part of this dialogue. As many of you had stated in the beginning, we are seeing now that the service delivery has changed, and particularly for Prevent Blindness and See Well to Learn, the constituents we serve are mostly low-income, underserved communities. We work exclusively in school districts and certified daycare centers, and we work exclusively in school districts that are serving low-income constituents as designated by the federal school lunch qualifying criteria programs. And so I wanted to take just a brief moment, give you a little insight into Prevent Blindness, and then thank Jessica Schifferman for the opportunity to focus today's discussion on what the board wanted to get out of it. As an organization, Prevent Blindness is the largest nonprofit providing vision education and services in the United States. We started in 1908. Here in California, we started in 1961, received our nonprofit licensing in 1966. The organization originally started as an all-volunteer organization providing vision screening services and then providing services for adult populations for AMD and diabetic retinopathy, ophthalmology, and optometry-based screenings. Since 1966, we've actually screened well over 1 million people here in California, both adults and children. The mobile program that I want to talk to you about today was started in 2011. And the impetus for starting the program, which we now call See Well to Learn, was it was based off of a program run at UC San Diego and Dr. Brown. And that program was looking to come up to the Bay Area, and through a network of discussions and funders, it was decided that Prevent Blindness, given our history and infrastructure throughout California and specifically Northern California, would be the best organization to take over that program. So in 2011, with some seed funding from the Tipping Point community, we started our See Well to Learn program. We today have a staff of about 14. This is our senior leadership team. We have a board of about 15 members, mostly principally made up of ophthalmology professionals. A number of optometrists are on the board too as well as people from non-vision related either healthcare or business backgrounds. Our focus when we started this program, as I stated, was to serve the greater Bay Area. And we focus exclusively in school districts and now in also licensed daycare facilities. The San Francisco area is pretty unique with a program initiated through the Office of Early Child Care and Education and First Five called Preschool for All. And they've made great strides in getting the majority of residents to be preschool, that are in preschool or get into the preschool curriculum. But I think, as everybody well knows, particularly for non-English language speaking populations and other populations, not every child goes to preschool. And so we want to make sure that our core mission is to get every child served at an early age. And our focus is principally at least in See Well to Learn, exclusively in the preschool aged, 3 to 5 year aged cohort. The program is run by Prevent Blindness, but in cooperation and in partnership with UCSF Ophthalmology. They maintain the clinical practice, they evaluate the exam records, and they calibrate with us as we might change exam criteria. We also have a partnership with UC Berkeley, where we work with them in their 4th year residents and a supervising OD from the UC Berkeley School to provide on-site optometry-based services aboard our iBus, and we'll talk a little bit more about that as well. So to get into the specifics of our mobile program, we can flip to the next slide. We currently, in See Well to Learn, have one mobile clinic. It's a 31-foot converted Winnebago that we had retrofitted to be a mobile optometric clinic. It has what we would refer to as one lane with a theoretical capacity of about 20 exams per day, but we try to do about 13 to 15 exams today. Given that we focus on preschool populations, I think, as most people would recognize, it's tough to say exactly at the start of the day how an exam may go. And we try to calibrate now with 46,000 preschool exams under our belt. We've got a pretty good inclination of the challenges we're going to face. But here are some shots of our iBus. We post all licenses for all of our optometrists in a specific location in the iBus. In addition, all publicly required notifications are also posted in our waiting room. We have a waiting room that will hold up to about 10 people, and I'll explain to you how we use that with our health education practice too as well. So as I said, our program goes exclusively into preschools, and the way that we work is really a 3-phased program. The first phase is we go into the classroom with 2 certified vision screeners, and we initially provide an auto-refractive examination to every child in that classroom. We currently use a device, a RetinaMax device, and our screeners screen each child in that classroom. And by the way, let me please just take a step back. It is an opt-in program, so the parents opt in or choose not to have their children screened, and we work through the schools to provide this information. And it is a close partnership with the schools that we serve and the Head Starts that we serve. So we go into the schools and we provide an autorefractive examination. For the children that don't meet the criteria of what we call passing in that examination, they are then selected to come back and do a full iBus-based examination. So approximately 2 to 3 weeks after the initial autorefractive exam, we come back to that school with our iBus. That iBus has a licensed optometrist on board. They have 2 Prevent Blindness staff members on board, an iBus operator, and a bilingual health educator. When they come on that bus, we redo the autorefractive exam, so we want to revalidate that it wasn't a spurious result. And assuming that we revalidate that result, then we do a full cyclopedic eye exam on board the iBus. And as you said, that is time-consuming. It is approximately about a 30-minute wait. Hence, we have that waiting room. And so all the children from the supervising OD receive a cyclopedic exam. During that waiting period, we require a parent or parental guardian to accompany them. So it is important for us that we do not lean on the teachers to provide this service. We really want to get the parents engaged at an early age in the eye health and education aspects with their children. And so during that waiting period, we take advantage and we have a number of educational videos that are both in English, Spanish, various other languages, Cantonese and other languages, where we talk about common refractive errors. And the whole idea is to educate the parents why it's so important at this early age where there is a connectivity to social and behavioral development and eye health, and how eye health is linked to early academic success as well. So based on the results that our optometrist provides, if the child is deemed to need glasses, we actually work with the parent and our bilingual health educator and the child, and we select the frames that are on our iBus. We have a partnership with an organization called Miraflex. We've been at this for a number of years, and I think everybody here might attest, particularly with pediatrics, getting a child fitted properly in eyewear can be a challenge. And one of the core goals, and I think a differentiator of our program, is we really focus on the compliance piece. So we want to ensure that once a child is given glasses, we actually track them for 60 or 90 days with the goal of making sure that they wear their glasses. And we have a series of processes and checks that we go into place with the parents, with the teachers. We also have a partnership with the UCF School of Nursing that are often back in these preschools doing a variety of examinations, blood testing, height and weight measurements. So we have a number of different ways where we collect data on compliance. The real driving force is getting the glasses prescribed to the children is often the easy part. Getting them to wear their glasses and improve visual acuity is the real key driver. And that's where, frankly, the real work is engaged in our program. So we have a team of people that then, once we prescribe the glasses, will go back to the school. It takes about 2 weeks. We have a partnership with Essilor. We order the glasses directly from Essilor's lab. We have a partnership with UCSF Ophthalmology Department. They will then fit the glasses in the frames. And then our certified vision screeners will take the glasses to the school, fit them on the child, and then start the process of what we call compliance and management. And that is a 60 to 90-day process, again, where we work with them. We do a series of at least 3 checks. And then for the children with the most severe or highest levels of prescriptions, we actually do what is known on the next page as a visual acuity after test. Again, checking the acuity levels. The whole focus of our program is that there is a pre-intervention diagnosis and then a sort of post-intervention diagnosis. And our goal is to ensure that we manage compliance and hopefully that we're improving visual acuity too as well. Next. Just for being cognizant of time, I think I've talked a lot about this. I have a series of forms that I can make available. Again, this is an opt-in program. We require parental consent. We require parental participation. The program is run through the schools or through Head Starts. We have site-specific managers that manage all the interactions at each individual site. Next slide, please. The way that we do the prescribing and tracking is we have a HIPAA. We've built, based on REDCap and some other databases, we have built a cloud-based HIPAA-compliant database. It's an optimized and customized Salesforce system specifically for eye exam and patient records. All of our records are stored in the cloud, secured under HIPAA, so we maintain all of the electronic health records. These records are also provided upon each exam. The parental guardian of the parent is given a copy of their records. We also work very closely with the schools because we want to make sure that if the child has a medical home, that their vision health records are part of their health record too as well, so we work very closely. When we come across situations that are beyond a standard refractive diagnosis, we have a very large network of doctors that we're able to work with. However, our goal is not to be a program that makes referrals specific to specific optometrists or specific ophthalmologists. We will work with the patients if they have a preference. Again, the majority of our constituents are on Medicare, Medi-Cal programs, so we have to work with them to find a certified doctor, and we work with them and we work very closely with them to make sure that they get into the follow-up care if it's beyond what we're able to provide. Next slide, please. I just wanted to share with you some criteria that was established with UCSF Ophthalmology for what we call our visual acuity after tests for the children that we come back 6 to 8 weeks after we've done their initial prescription and fitted them for their initial frames. Lastly, again, this is really a focus on family engagement, getting the parents and guardians involved in their children's vision health and academic success early on. We provide what we call glasses or cool parties. And so we do these county-wide. We have one coming up on Saturday for the children that we served in the school year that just completed in San Francisco. We do a party. It's an opportunity where we invite families and all of the children that were prescribed glasses. We do refittings. We provide free replacement frames at these glasses or cool parties. We do surveys and sit down with all of the parents individually. We want to work with them to see if they are having any challenges getting their child to wear their glasses. if they have any questions. We provide ongoing follow-up and ongoing care. And it's also a great opportunity for our funders as a nonprofit, right? We are funded principally through donations, grants, et cetera. We receive no federal funding, although we do receive grant and nonprofit donations. And it's a good opportunity for our partners at UC Berkeley, UCSF, and our healthcare funders to also interact with the program. We use these parties as a way to collect data and further and bolster our evidence-based growth of the program. Lastly, I think it's
About
important.
1 minute.
In closing, we do occasionally come across children that are already under care and have glasses. Our protocol is if they do have glasses, because we're working with low-income families, if they provide us a valid prescription within the last 6 months from their preferred ophthalmologist, we will actually provide them a free pair of glasses and fit them with a second pair of frames too as well, even if they're under care. So I guess in closing, here are some key statistics. We've screened about 46,000 children. Roughly about 43 to 44% are Hispanic or Latino, 27% Asian, 17, almost 18% are African American, and then the balance either Caucasian or in San Francisco and the surrounding communities. You know, a broad potpourri of other ethnicities are served as well.
Great. Thank you.
Thank you.
Hello again. President, Board, thank you so much for welcoming us today.
Speak in the mic.
Thank you so much for welcoming us today. We're very excited to be here and for the opportunity to present to you. Again, to kind of reiterate, I'm here from 2020 On-Site. We are the largest mobile optometry practice management company in the United States. We work with independent optometrists to serve companies, schools, community health organizations, hospital systems, and more. And so really have a focus on delivering incredible access to care in a patient-first manner. So as an overview, we are currently operating in 3 markets, Boston, Atlanta, and Chicago. We have over 250 corporate clients in 3 years of operation, and we've completed over 1,000 visits to various sites. Currently, we are at a pace of completing over 12,000 exams per year, and approximately 5% of those are referred out to our multi-practice ophthalmic referral network. In addition, we have a sustainable social impact program where we serve middle schools and high schools in both Boston and Atlanta, which is across 4 different school districts and providing access to over 60,000 students. So thinking about the purpose of optometry law, right? So consumer protection as kind of number 1, and then number 2 being efficient delivery of services, right? And so when we think about that framework for understanding how we're delivering care and what the value proposition is for both the community and the patient, what we see is that 2020, so on-site mobile optometry is an easy service. It's low or no cost. So when we think about the Uber of bringing services to people, this is a way to share that, a way to share on-site services and not be constrained by building your own on-site clinic or having to put up that upfront investment. It's amazing for the population because of the access it creates and because of the continuity of care that it delivers. And it works with existing benefits. So there's, you know, it doesn't work outside of the existing framework. For the patient, it's amazing because it's convenient. It is a way to deliver best-in-class quality, and it is a way to do it in a cheaper fashion because you don't have the overhead associated with a brick-and-mortar location, and so that's a big win. In addition, patients are actually channeled into the private practices so that they can get their follow-up care that's needed. This chart here is a snapshot of our patient satisfaction ratings. And so we collect patient data by text message and by anonymous email survey. where patients can respond and say on a scale of 1 to 10, would they recommend us to a friend or colleague? And 97% of our patients rate us a 7 out of 10 or higher. And I've included some testimonials that we've received. And as you can see, the feedback from patients is overwhelmingly positive, and I'll quickly read some of them. The most personal attention I've ever received at an eye exam, plus everyone was so knowledgeable and nice. I've been putting this off. This was so convenient. This is my 3rd year, and I plan on it next year too. And the doctor took the time to explain each test and result and gave us the opportunity to ask more questions. As you can see here, it's trite to say that 75% of adults require vision correction. Probably not surprising also that 80% of people don't like going to the eye doctor. They don't, it's not something they think, hey, I'm really looking forward to doing this, right? So when we look at the traditional experience, we think about people calling to their optometrist, penciling in the appointment. If they're in a rural community, a suburban location, or an office park, they have to leave work, get into their car, sit in traffic. They have to wait. There's frequently a waiting time. They then get a paper prescription that can be lost. And then when they purchase their glasses, they need to go back for the fit and adjustment. When we look at this sort of challenge that's in front of us in that traditional experience and sort of this sharing economy of a new experience, the way that 2020 works is we sort of created this Apple Store for your eyes inside of a 36-foot vehicle. It's incredibly convenient, it's faster, it's cheaper, very highly recommended from patients. So typically we'll work with HR organizations within companies. If it's at a community health center or a school, we'll work with a health liaison at that individual location. That individual will then either connect us with their constituents by email, local, on-site advertising like digital boards, paper materials. In the case of health centers, there may be phone calls or mailers. Patients are then able to book appointments either online, by phone, or through paper signups. Those patients then receive digital reminders. Then they step outside for their eye exam. And previous slide. When they get their eye exam, what happens is they're actually welcomed, as they come onto the Mobile Vision Center, they're welcomed by a store manager. The store manager completes the paperwork, checks the patient in, notice of privacy practices, recognition of financial responsibility. The patient then goes to the associate store manager for their pre-testing and workup, then goes to the optometrist for a comprehensive eye exam, and is then able to come out and purchase from a selection of over 300 frames. They receive their prescription digitally by the end of the day, and the glasses are actually fit on the spot and then delivered to the patient within 2 weeks. Next slide. So in one particular, I'll share one particular story of a woman at a company that we saw. When she came down, she had been complaining of headaches for some time. She had specifically mentioned that she put off an eye exam, even though it's something that traditionally she had done on a fairly regular basis. Partway through her screening, it became very clear that she had a swollen optic nerve. She was immediately referred out to get a MRI on an emergency basis. It turned out that it was nothing to be too concerned about, and it was something that she was able to manage. But had she not had that access and convenience at that point, that asymptomatic, outside of some mild recurring headaches, that issue would not have been detected and could have become very serious. So when we think about how we deal with follow-up care and continuity of care, patients who visit us can visit us at another location where our mobile practice is nearby. They can visit one of our multi-practice ophthalmic referral partners for follow-up, or we can work with them to schedule referral at their clinic of choice. We have multi-year agreements with the partners that we work with so that patients can book next year's appointment at the time of service. Patients are able to phone in to our central shared services patient support line for any help during the day between business hours. They're also able to email us 24/7. And patients can be connected to the optometrist by email or phone if necessary. We can share patient health records on signing of a release of health information form, and we also have an online patient frequently asked questions page. Records are, retained. We also have standard policies and procedures relating to safety, OSHA, HIPAA compliance, standard of care. So I'll just quickly run through some pictures of the inside of the Mobile Vision Center. Just next slide. There's a picture of the frames. There's a picture of some of the pre-testing equipment. Next slide. And here's a picture of the exam room. As you can see, very clean, open, really offering a patient experience very, very similar to a high-end brick and mortar, right? And so in situations where patients don't have access because they live in, older areas, less economically fortunate areas, they don't have access to a clinic that is, this advanced. Licenses and consumer notices are displayed. We have sharps containers. It's clean daily. We have running water with soap, hand sanitizers, Cavicide wipes, disposable gloves, facial barriers that are available when needed, that sort of thing. Next slide. Again, just same picture from before. Next slide. Just drawing the attention to some media attention that we've received, sort of shedding the service in positive light, recognizing the excitement around the service from patient communities, and just providing some outside validation. Next slide. So here, getting back to this point around sort of, the sharing of services, right? What was previously something that would require $1 million capital investment to have an on-site brick and mortar clinic for a location in an office park, a school that's in a rural district, whatever. This is a quote from a Fortune 50 company client of ours who has 100,000 employees, over 100,000 employees. They say, on-site care makes sense. That's why we have a physician on-site in our 8,000 person Ohio office. With 2020, now it's economical to offer vision care at all of our offices. And so we actually open up vision care to sites that have as few as 20 people, or even fewer, that need to get appointments on a single day. Organizations that have only 100 employees, even if they're in rural locations, and there's no local providers who accept their insurance. This slide here talks a little bit more about our schools program. As I mentioned, we partner with districts in both Boston and Atlanta, providing access to over 60,000 students. We have provided over 1,500 exams to date. 75% of the students are on Medicaid. On analyzing some of the data, we see that visual impairment defined as worse than 20/40 among Medicaid-covered students was at 16.6%. This is in the middle school and high school age ranges. We see students who are in grade 11 who have +7 prescriptions, who have never had an eye exam in their lives. They can't even get on the Mobile Vision Center without assistance, and they're in the classroom. It blows my mind that these people are able to pass their classes. There's a picture with Dr. David Gibson, our optometrist in Atlanta, and a quote from the Tech Boston Academy school nurse. We also partnered with Prevent Blindness on our bid for the Chicago Public Schools schools program to deliver optometry to students there as well. We've also been approached by multiple vision insurance carriers as well as hospitals and community care organizations to do diabetic eye exams. As you all know, there's a huge need in the diabetic population, specifically diabetic Medicaid population, of individuals who don't comply with their care and don't actually get their eye exam. We're also currently working with two of the contracted associations of the Department of Veteran Affairs to deliver eye exams to veterans who, as you know, is also a very chronically underserved population, frequently in remote locations that don't have access. One of the second last thing I'd like to speak about today is some legislative considerations, and I don't want to stray too far off the topic here, but want to make a case for mobile optometry.
2 minutes.
as a broad case. So first, very clearly, regulated mobile optometry is absolutely essential to provide adequate care and access in today's day and age. Mobile optometry increases access and engagement in care. It also removes healthcare inequities. The students at Atlanta Public School who are on Medicaid get the same exam as the executives at the headquarters of Georgia Pacific. It's truly phenomenal. It expands optometry business models. It means that there's improved visual care and engagement in chronic health conditions. It means that it increases the market for vision care services because people who would not otherwise receive eye exams receive eye exams. It also means that optometrists can compete with new technologies like digital refraction, which, as you very well know, has much bigger consumer protection issues than mobile optometry. From a practical matter, as we think about access, there are a few more technical items that I wanted to address and state why they should not be required in any proposed legislation around the design of mobile clinics. Restrooms should not be required. In almost every situation, restrooms are nearly accessible in a other local building. Wastewater is also at risk of being cross-contaminated there. Cold or room temperature water is completely sufficient for any needs that you would have related to vision. Hot water would create unnecessary cost without a clear benefit. And then accessibility, wheelchair accessibility should not be required as a broad rule. Where needed, it's very easy to determine if wheelchair accessibility is needed, and then you can schedule for a clinic that provides that care. Lastly, just a quick overview of our team. Founder and CEO is a former venture capital and private equity investor and has worked at the Bill and Melinda Gates Foundation Healthcare, previously McKinsey consultant. Chief medical officer is a corneal transplant, cataract, and refractive surgeon. And that's it. Thank you so much.
Thank you. So this will be the Vision to Learn slides. Good morning, everybody. I'm Damian Carroll. I'm the National Director of External Relations for Vision to Learn. Thank you for inviting us to be part of the panel today. We've been pleased to have several opportunities now to speak with the board and participate, and we're really very appreciative of your fine attention to mobile vision care, increasing access for students to vision care, and we're just very, very pleased to be here today. Vision to Learn is a 501c3 nonprofit that was founded in 2012 by Austin Butner. He's a Los Angeles philanthropist, served as deputy mayor in Los Angeles, was also the publisher of the Los Angeles Times. And at the time, he was looking for a way to help kids succeed at school. Received input in regards to Los Angeles Unified School District that as many as 1 in 5 of the students at the school in the low-income areas, very high Title I schools, were unable to see the board at school due to not having the glasses that they needed to succeed in class. As a result, he started the program back in 2012 to serve these students, and since then we have provided both in Los Angeles County and up in the Bay Area for the last few years over 75,000 exams and nearly 6,000 glasses to students K through 12 in California. Let's go back to the first slide, please. So the issue that we all know is in schools in low-income areas, 1 in 4 students have vision problems that can affect their ability to achieve in school and engage in life. Vision to Learn, based on the estimates of students that we have treated in high percentage Title I schools, estimates that about 250,000 in California lack the glasses that they need to read a book, see a board, or participate in class. These are the students that Vision to Learn was founded to provide care to. About 80% of all learning in the child's first 12 years comes through vision. So this is an issue that has an enormous impact on students' academics, on their classroom behavior, on their ability to participate in and enjoy school. And a study in the Journal of Public Health Management and Practice found that 95% of incoming first graders who need glasses do not have those glasses. So it's a pernicious problem that we need to find solutions to bring glasses to these students that are not currently gaining access to optometric care. In addition, as many as 74% of adjudicated adolescents in juvenile halls have undetected vision problems. And this is a good illustration of what can happen to kids if they don't get the glasses that they need to succeed in school. Over the long term, this can have impacts if they're unable to read by third grade, reach third grade reading proficiency. It results in a higher dropout rate, and it can have a potentially very negative impact on a child's life if these are not identified early and treated. Go back to the previous slide, please. So this is an example of one of our clinics. All of our clinics in California are based on Sprinter vans, Mercedes Sprinter vans. They have an optometrist and an optician on board, and they travel to school sites to serve kids at school during the school day. Next slide. We have 6 full-time mobile clinics in California. Full-time means these clinics are going 5 days a week to schools. Each clinic is seeing approximately 28 kids per day at school. We serve 55 school districts in California. We enter into MOUs with school districts so that they understand the school district's responsibility, which involves, in most cases, vision screening the kids before we come and sending out and receiving consent forms for the care that Vision to Learn provides. 75% of the students served by Vision to Learn qualify for free or reduced lunch. And of course, in many schools, that number is far higher. That's an average. We go to schools that are above 65% free and reduced lunch programs. So we're not means testing kids, but we are going specifically to the schools in high poverty areas. And we now operate in 9 states. In addition to California, you can see that there was 8 other states that Vision to Learn currently has a service in. We're bringing that service principally to concentrated urban areas, although we also have a clinic in Iowa that serves some rural communities. Hawaii also serves some rural communities. But principally, we're in larger cities, Baltimore, Detroit, Jackson, and we serve essentially the entire state of Delaware. Next slide, please. So our standard exam procedures, we work very closely with school nurses. In fact, we presented a couple years ago to the California School Nurses Organization, and we hear the same story again and again in district after district. The school nurses are doing the mandated vision screenings. They are sending home recommendations to parents for those children that fail those screenings, saying your child needs an eye exam, they potentially need glasses. And in most cases, the child does not get the eye exam, they do not get the glasses. So these screenings are a valuable tool to identify kids that need those exams, but they're not resulting in the access to the exams. And that's the piece that Vision to Learn is designed to fill. So the school nurse performs vision screenings. We also ask the nurse to fill in the non-mandated grades so that every child at the school has the opportunity to be referred for care. And those vision screenings then result in a note being sent home to parents, letting them know that Vision to Learn will be coming to the school, along with a consent form that they can fill in and return for care. And incidentally, our estimate is that about 500,000 kids have received a screening to facilitate Vision to Learn coming out to school. So that's additional grades that are being screened by the nurses, taking additional time to do these screenings to catch all the kids at the school so that, as Austin likes to say, the little sister gets the glasses, the older brother also gets the glasses. We're not going to leave any child behind at school that needs the care. The mobile clinic then comes out to the school. Each clinic has an optician and an optometrist. The students come out to the clinic about 2 or 3 at a time. They're escorted by a volunteer at the school. And they are checked into our electronic medical records database by the optician. They then get an autorefraction. They go back to the optometrist, who's got the chair and 4-opter. And if they are prescribed glasses, They come back up to the front of the clinic where we have a wide variety of frames for the student to choose from. The glasses are then produced by Classic or Capital Optical, and we come back about 2 to 3 weeks later. An optician then fits the glasses to each child, provides them with information about when to wear the glasses, how to care for the glasses, and if they are damaged or lost within a year, the glasses are fully warranted and we will produce a new pair and send it out to them. And so they get all the information about how to get in touch with Vision to Learn in that circumstance. We serve every child at the school regardless of insurance, immigration status. It's all totally free to the kids. Next slide, please. From the beginning, Austin wanted to make this program one that was based on best practices, evidence-based. We are looking to serve as many kids as possible with a high-quality service while making it as efficient to also serve that need to be able to reach as many kids who need these glasses as we can. UCLA Mattel Children's Hospital performed 2 studies of our program, one quantitative based on students' academics of the kids who received the glasses. You can see they looked at math and reading grades and found that each of them, after an initial decline of the kids who needed the glasses, once they're provided the glasses, their grades switched directions, started to go back up again. Particularly boys' math grades saw an 8% improvement in GPA after receiving those glasses. They also performed a qualitative study with interviews of parents, teachers, principals that found overwhelmingly 95% of those interviewed said their child would not have received glasses without Vision to Learn's intervention, and described kids excelling in academics, kids who had been previously identified as having classroom behavior issues were suddenly able to participate better in class, and a lot of feedback that said we didn't realize that the issue was that these kids needed glasses. So we're identifying these kids with the help of school nurses, and we're bringing them that care so that they can get the exam and glasses and succeed in class. Our model is cost effective. The total cost of service, including glasses, optometrists and optician, transportation for the clinic, all told, is less than $100 per child. And that's a big reason why we're able to serve so many kids. Next slide. We are also working on additional studies of the program. A follow-up by UCLA Mattel Children's Hospital is comparing students who were provided glasses by Vision to Learn with a control group of their peers. So really working to nail down the causative effect of giving kids glasses on their academics. We also are excited to be working with Wilmer Eye Institute at Johns Hopkins University. They are doing a 3-year study of our program in Baltimore. That is they've separated the schools into 3 roughly equal groups so that they can be compared, the schools that we serve in the first year with those we serve in the second year and the third year, to really get a sense of nailing down those academic benefits for the students that we're serving in the Baltimore public schools. Next slide, please. We have a wide variety of community supporters and partners who we just would not be able to succeed without their help. I'll call particular attention to some of the sports teams down on the bottom rows. Most of our clinics are decorated with sports stars from teams that are partners with Vision to Learn, often sports stars who wear glasses themselves. You can see Justin Turner and Adrian Gonzalez on the bottom row there. They came out to a school near Dodger Stadium and participated in a dispensing event for some kids. Justin Turner told the kids, "I've worn glasses since the 3rd grade, and I wouldn't be playing Major League Baseball today without them." So we really work to make our experience for kids one that is enjoyable, that will result in them loving their glasses, wearing their glasses, and continuing to appreciate that these glasses are sort of a prize for these kids. As I'm sure most of you know, the stigma that maybe when we were kids that kids didn't want to have glasses has kind of gone away. Now we actually deal a little more with kids who want a pair of the Dodgers glasses, and so we have to look for malingerers, I guess is the term. But the and I think Seth spoke to this group dispensing atmosphere where you have all the kids at the school getting their glasses at once means no one child has to come to school on their own with their new glasses and be the center of attention. They see their friends get the glasses, they see their cool kids get the glasses, their teachers are really school-wide focused on these are the kids that are getting the glasses today so they can keep up with them and remind them to wear their glasses and notice if they don't have them so that we can get them a replacement pair. We also have a lot of support from top leaders in California. Governor Jerry Brown came out to one of our dispensings in Sacramento. He's been a big supporter of the program. Kamala Harris, when she was Attorney General, came out to in Oakland. And we have a great project right now in Long Beach. We are serving every school in the city of Long Beach. It's the third largest school district in California with the support of Mayor Robert Garcia. These are just a couple of quotes from principals of schools that we did a big email recently where we sent out the results of the work that we've done in the past year to each of the schools that we serve. We got back a large number of emails from principals echoing these sentiments. You know, teachers, principals, school nurses, they're the ones on the ground who really notice the impact for these kids. And, you know, they're thrilled to work with us. They want us to come back as soon as we can. And they really notice how much the kids appreciate the glasses and how much the service has meant to their students. Next slide, please.
1 minute. 1 minute left, okay.
Okay. Vision to Learn, of course, our program is geared towards getting kids the exams and glasses that they need. So if our optometrists identify additional issues that need follow-up care, we have a referral process where we let the nurse, the parents know that the student needs follow-up care. The optometrist will call the parent to reinforce this, and we give them a referral form that has local optometric and ophthalmologic providers who accept Medi-Cal or sliding scale affordable service. And of course those are particular to the region that we're serving in, so the partners will be a little different in San Francisco than down in Los Angeles. We have referred since 2012 over 10,000 students for follow-up care. And
thank you.
Oh,
sorry.
Yeah, no problem.
Thank you.
Continue?
Yeah.
Yeah. Hello, I'm Gil Melgoza. I manage the mobile clinics program at VSP. And our mobile clinics programs operates very much like these gentlemen over here. And so I'm going to tell you about our mobile clinics program as if you were a patient walking through our mobile clinic. We have 3 mobile clinics. All 3 mobile clinics have 1 complete exam lane, a dispensary and pretest area, and also an in-office finishing lab. So with our lab in our clinics, we can provide a pair of glasses to a patient in about 15 to 20 minutes. We partner with organizations who currently provide outreach. We support their program with ours. We partner with organizations such as Boys and Girls Clubs, Special Olympics, homeless shelters, community events, and some Title I schools. At Title I schools, we provide the child 2 pairs of glasses, 1 to keep at school with the teacher and 1 to take home to use at home because kids are constantly losing their glasses. So it's it's something great that we worked out with school principals and school nurses. Our program was originally designed for disaster relief. What happened was our network doctors were impacted at Hurricane Katrina and Rita, and so a team went out there to help these doctors get back on their feet. So they noticed all these other mobiles like Tide, Loads of Love, and other mobiles such as, so we thought, okay, let's put together a mobile clinic. So since then, we have 3 mobile clinics. They travel all around the country and provide eye exams and glasses at no cost to the patient. These are all fully funded by VSP. When not at disasters, we didn't want these clinics sitting in the parking lot, so we do outreach throughout the whole year. At this point, we do about 150 events a year and turn down hundreds of events a year. The need is out there, and we work with organizations that help us qualify our patients and our Our patients must be underserved, no vision insurance, and have not used our program in the last 12 months. Okay. So when you come up to our mobile clinic, we hand you a patient packet. And in that patient packet is an exam form, an order form, patient history, and HIPAA, the HIPAA compliance explanation. So that is filled out, and a VSP employee observes or reviews this document, and if there's anything in the health record that they've just filled out, we bring that to the attention of the optometrist. Okay. So once the paperwork is complete, the patient steps into the mobile clinic and gets pre-tested. We have a 3-in-1 Nidic autorefractor, and the patient gets pre-tested there. Once, and before the patient sits down, we clean and disinfect in front of that patient so they see that it's clean every time. Once the patient receives the pretest, they walk into the exam room and get a comprehensive eye exam. It's a full doctor's office on wheels, but what we do not do is provide medications. The only thing we provide is dilation drops, and the reason being is that we have a relationship with local areas for referral processes, and we refer patients out to a location that has free services or on a sliding scale, and the doctor helps us find those locations. So we're able to provide a list to a patient who needs further care of a location, a phone number, and sometimes even set up the appointment for them on site. Once the patient gets a comprehensive eye exam, they step out into our dispensary where they're able to choose a pair of glasses. That's the pair of glasses that they will be taken with them. So if we have the prescription on the clinic, we only do single vision glasses on the clinic, we'll go ahead and make them and provide them to them in about 15 to 20 minutes. If it's something more complicated than single vision, we do send those out to our VSP lab, and those are made, and then we make a some kind of coordination effort with the entity that we partnered with and send them back to them, and then they contact the patient that your glasses are in. VSP will then send out an employee, an optician with that experience, and help them fit those glasses when those glasses come back. We provide them a copy of the HIPAA regulations. We explain to them how they can get a hold of us. We give them a slip with all the phone numbers if there's any issues with their glasses to contact us. And also we can refer them to the doctor that was volunteering on the mobile clinic to help them adjust their frames afterwards if they have any questions. It's a great program. We love it here in California. We have served 18,000 people who have received glasses and an exam, and we continue to do this throughout the year. And some of the board members have visited our mobile clinics and would be happy to give them another VIP tour for all the new members on the board. If you'd like to, I'd be happy to coordinate that.
Thank you.
Okay. So my name again is Meredith Whiteside. I'm an associate clinical professor at UC Berkeley Optometry. And I'm talking today a little bit about a program that we had, ended in 2013. So the program that we had was a program that we cared for patients that were kind of on the opposite end of the spectrum of that end. So I saw primarily older patients. And these patients were typically in their late 70s to, my oldest patient was 110. And they had an inability to go out to the eye doctor. That was a requirement of it. So we would go to nursing facilities and occasionally a private home. It was referral only, and the people that we would take referrals from was typically a medical provider. So it had to be a physician or a nurse practitioner, and there had to be a medical indication for us to go to see them. The services that we provided were comprehensive or occasionally problem-focused eye care. And the typical demographics of the person that we saw was a homebound older adult. Oftentimes they were bedbound or in a wheelchair. They typically had several chronic conditions, medical conditions, a lot of cognitive disability, and multiple, diabetes, the whole run of things. In terms of that, like how our service worked, the way that they would get scheduled as a responsible party for the patient, because many of our patients had cognitive disability, or social services would contact the school. And before the examination was scheduled, we would need a consent form signed by the responsible party. And the consent form went through, told them who we were, how to contact us, and outlined what services to expect from us in terms of fees and, glasses, how a glasses prescription would be provided. We also needed a referral form from the primary medical provider that certified that they had a medical need for this, so that it wasn't that we were just going to somebody's home and they could go out. It was that they were unable to leave the home. And we also got medical records because we wanted to establish what type of care the patient needed. When the appointment was scheduled, so we'd have all of those forms completed before we went. The appointment would be scheduled. We'd go to the facility. We'd set up the equipment, and then we would perform a comprehensive examination. It would include case history. We'd assess ocular motility, binocularity. We would perform a refraction, tonometry, visual fields, slit lamp and dilated fundoscopy. Examination notes were given to the referring provider and or the nursing facility, so we would give a copy of that. And the patients, or the responsible party usually, were given a copy of the spectacle prescription and the eye examination records. If desired, we had a small collection of frames that we would show the patients if they wanted to get frames through us. However, it wasn't required. At that time, it was a lot more difficult to, they didn't have online glasses and things like that, so that wasn't even an issue at that time. But we would provide glasses if it was desired, if they wanted it. And then follow-up was scheduled as needed. Annual comprehensive examinations required a re-referral, so we didn't schedule them automatically. We had to get a referral from the primary care provider and the responsible party. If needed, patients were referred to local specialists. So, for example, we would have patients that had exudative macular degeneration, which requires ophthalmological care. We had a list, and I kind of contacted the local specialists in the clinics there. And in cases where, it wasn't too often that we needed a same-day referral, but in those cases where there was some type of emergency situation, basically I would contact the responsible party and also contact the local doctor to arrange for care. And that's about it. Our contact information was provided on the examination notes that we gave to, the people who referred to us in the facility. And also, when we did do glasses, they would select the frame. We would take the order back with us, process it, and then send it to them. And we also fitted them with it. Oftentimes, well, all of the times, we would have our contact information when we sent the glasses back. So it was, they contacted us. It was on the examination notes. It was on our prescription that we released, and also on if we provided any eyeglasses. Thank you.
Do we want to take maybe a 5-minute break to use the
Here's what I'm
facilities?
proposing. No, how about if we take, yes, a 5-10 minute break, then we'll come back if we could to do our panel. We're scheduled for a working lunch, but we'll take, instead of eating on webcast, probably another 10-minute break to just quickly start our 15 minutes, start our food, but we need to work during lunch in order to make it through our schedule. So does that sound good if we take 10?
10 minutes right now?
10 minutes right now, and turn your time clock on, Rachel. No, just kidding. All right, thank you. We'll take a 10-minute break.